today here. My name is Jung Chi. I'm one of the elders at Grace Toronto Church. I'm also a physician. I gave the talk here a few months ago, so I think some of you are familiar. So welcome. Nice to see everyone again, and those of you who are new here, welcome as well. Grace Toronto Church is a church where we endeavor to preach the gospel, and not only preach the gospel, but we really want the city itself renewed through the gospel. And we do that through not only personal conversion, formation of community, and doing social justice, but also through cultural transformation. And what cultural transformation is really thinking about what the impact of the gospel is in the culture, in society. And we seek, at the Faith and Work event, we seek to equip and connect and help Christians and mobilize Christians to think through what this means in terms of their work. And we believe that work is good. God created work, but at the same time, work is hard, and there's something fallen, and there's something corrupted about work. And the gospel is that God is doing something about that. And the gospel is that although we live in a fallen world, through this man who lived 2,000 years ago named Jesus, his life and his death and his resurrection, that has changed history. It has changed the way we think about a lot of things, changed many people's lives, and it has changed the way we think about work, and especially healthcare. So to that end, we have Dr. Ewan, Goligher here to help us realize that. Dr. Goligher is an intensivist. He specializes in critical care medicine. He practices at the Toronto Western Hospital. He obtained his MD at UBC and did his residency in internal medicine and critical care here at the University of Toronto. He is pursuing graduate studies, focusing on respiratory muscle research, especially acute lung injury and mechanical ventilation, and specifically regarding ventilator-associated diaphragmatic injury, which is very cool and interesting. So today he's going to talk to us about end-of-life and end-of-life care from a Christian perspective. So please help me in welcoming him.
All right, thanks, Jung, for the kind introduction, and thank you to everyone here for coming out this evening. I really want to thank Grace Toronto for hosting this event to talk about a subject that I think is critically important. And I've got to say that I've had a chance to get to know several members from your church over the last couple of years, Darius, John, and Paul, who are here this evening, and several of others, and especially through our activities in the network of Christian scholars. And I've got to say, I'm just so encouraged by them, by their love for the kingdom, by their love for Jesus, and I'm just really thankful for your church and what you guys are doing, and just hosting a conversation about these issues, I think is awesome, and I'm privileged to be here this evening. I have a couple of opening caveats. I think it's probably important for me to say that the things I'm going to say this evening, I'm not speaking on behalf of any institution with which I'm affiliated. And secondly, I have no formal training in bioethics. I'm not a bioethicist. In fact, as you heard, I'm an aspiring respiratory physiologist. I really haven't had a lot of interest in bioethics in my life, although I got a reasonably solid basic training in medical school. But ever since I heard physician-assisted death publicly endorsed at a medical conference for the first time this year, I've really been forced to dig into the literature, review and appraise many of the arguments, and so this is an opportunity for me this evening to sort of summarize all that I've learned myself over the last year. And so I'm not someone here who's speaking from the ivory tower. I'm really the guy in the trenches who is forced to address end-of-life care decisions all the time. So over the next hour, I want to present a view that the critical determinant of how we look at the ethics of ending life is our view of the very end or purpose of life, And I will argue that it's possible to know the true meaning and purpose of life, and hence to know the answer to the issues before us. I was a fourth-year medical student when I first encountered the intensive care unit, and I fell in love immediately. The intensive care unit is an exciting environment. It's a dynamic environment. The patients many of them are incredibly sick. Their condition is changing rapidly. Diagnosis and therapy are of the utmost urgency. You see an incredibly wide range of medical conditions. Many of the patients will have many concomitant medical problems, and so you're constantly thinking, you're constantly responding, and you can see the response to your interventions in a very short period of time. And it was really a very stimulating, enjoyable environment, and even as a medical student, I really decided this was going to be for me. I remember the first time I ever witnessed a withdrawal of life support. The patient was a woman in her late 50s who had recently retared, and her husband had also retired, and they were sort of enjoying their early retirement years, and she unfortunately developed a metastatic cholangiocarcinoma, which is a tumor of the biliary tree, and those of you in healthcare will know that that's a devastating malignancy that rapidly progresses. And she presented to the emergency room faint and dizzy, and turned out to be having massive intra-abdominal hemorrhage, because the tumor was basically lining the entire interior of her abdominal cavity, and blood was just oozing off of the tumor. She developed a condition where the clotting system failed, and so really there was nothing that could be done. She was taken to the operating room. They opened her up, they saw the situation, and they said there's nothing that can be done, so she was brought back to the ICU. And it was a bit of an unusual withdrawal of life support, because the patient was actually awake and interactive. And I can still remember her in the bed with the endotracheal tube in, and her husband standing at the end of the bed, and then pleading with the attending physician to have the endotracheal tube out so that they could speak to each other for the last time. And he was reluctant. I think he was worried that she would develop immediate respiratory distress, wouldn't be able to talk, and it would just be horrifying for everybody concerned. But we actually pleaded with him too, and he finally relented, and the tube came out, and she was able to say her last words to her husband, and rapidly passed away. And I was so moved by that. I mean, I was newly married at the time. The idea of never being able to speak or hear my wife speak to me again was just emotionally devastating. And particularly at that stage of your training, you're just continually inserting yourself into your patient's shoes. So, the point of this story is really to point out that end-of-life decision-making is complicated, it's fraught with emotional and ethical challenges, and these are never easy situations to deal with. In fact, just 2 hours ago, I was withdrawing life support in somebody. It's really something that we're faced with all the time in the ICU. Most of us in this room will be faced with a decision about end-of-life care, either for ourselves or on someone else's behalf. Over 200,000 Canadians die every year. 70% of them die in hospital. 20% of deaths in the USA happen in an intensive care unit bed. The number is probably considerably lower here in Canada. But the reality is that most families and some patients will face decisions about withholding and withdrawing life support. And almost certainly there are individuals here in this room who will die during an episode of critical illness, necessitating decisions on your behalf about withholding and withdrawing life support. Moreover, the challenging issue of physician-assisted suicide is now on the horizon. A recent report in end-of-life care issued by the expert panel of the Royal Society of Canada recommended the legalization of physician-assisted death. It's been formally legalized in Quebec, and the law is to go into effect in December of this year. And as you probably know, the Supreme Court is currently considering the Carter case, which, if they ruled in favor of the plaintiffs, would legalize physician-assisted death across the country. So consequently, what I'm trying to point out is that the issues we're going to discuss this evening are of direct personal as well as potentially professional relevance to everyone in this room. End-of-life care raises significant questions about the meaning and value of human life, questions to which our world desperately seeks answers. And I argue, and I know many of you share this view, that the biblical meta-narrative of the gospel provides the only truly effective answer for this problem. Here's a roadmap for our time this evening over about the next hour or so, I want to review, first of all, some of the issues around withholding, withdrawing life support. Secondly, we're going to discuss physician-assisted death. I'm going to present the arguments in favor and the arguments against. We're going to discuss the significance of worldview, one's view of the end or purpose of life, and finally talk about how to respond to these issues, how to put our faith to work with respect to end-of-life care. In this case, really at this time, there are 4 basic ethical principles that clinical ethicists and physicians apply to making difficult ethical decisions. And those 4 principles are autonomy, non-maleficence, beneficence, and justice. This is the so-called Georgetown mantra. And basically, these are thought to be sort of the basic principles that need to be considered and respected when trying to decide what the most ethical or right thing to do is. So autonomy basically contains the idea of being able to determine or manage and make your own decisions as a self-determining agent. It means that you are put in charge of, to the maximal extent possible, the decisions that are made around your healthcare, so that what your doctor does should respect your values, your beliefs, and your goals in life. That's basically what's contained in the idea of autonomy. The idea of non-maleficence is simply the classic do no harm. We try not to harm people. Beneficence, we're supposed to aim for the welfare, the good, or try to maximize the interests of the patient. And then at the same time, there's the competing interests of justice, because occasionally patients' interests will compete with the interests of society as a whole. And so sometimes the idea of justice enters the equation. When first formulated, these values, the underlying basis for these values was really thought to be the intrinsic worth of the human person. But the problem, at least in the world of ethics and philosophy, is that people quickly recognized that there was no obvious basis for belief in the intrinsic worth of human life on regular secular ethical lines. And really what we've seen over the ensuing 40 years is a shift to the preeminence of autonomy, where autonomy has become the foundation for ethical decision making. So why do we need to respect people's interests and try to do them good? Because that's what they would want. Why do we try to avoid doing harm to people? Because that's what they would want. Why do we try to maintain justice and uphold the good of society? Because that's what people in society want. So ultimately, autonomy has really become the primary foundational value on which all these other principles are based. And so more and more these days, autonomy is really the primary consideration in making decisions about end-of-life care. So in this particular case that I shared with you about the pregnant woman with the devastating brain injury, her husband was called upon to act as her substitute decision maker, to represent what she would want on the basis of her own goals, values, and beliefs. And the good news is that he thought she would want to remain on life support to save the life of the child. And she did, in fact. The child was delivered some 14 weeks later, alive and healthy, as I understand. I'm not sure about the outcome of the patient. But this just meant to give you a sense of how one approaches these cases. Now, conflicts around end-of-life care are extremely frequent. I've been on call in the ICU for the last 2 weeks, and I've been embroiled in probably 5 or 6 of these kinds of conflicts. And conflicts arise basically over 2 basic issues. Either because patients and families don't accept the prognosis that they've been given, or they disagree on what the goals of treatment ought to be. So really when we're talking about life support, what we're generally aiming for is meaningful recovery, so that you're sort of back to the way that you were. You can carry on life as you did before. And that's not always possible. Sometimes we can't achieve those kinds of aims. And so conflict can arise because either people don't accept our predictions about the inability to achieve the kind of recovery that they want, or because they are willing to accept an outcome that in general the medical profession finds it difficult to accept. And a classic example that probably many of you are aware of is the case of Hassan Razzouli. This is Mr. Razzouli with his wife and children. Mr. Razzouli, this is really just an awfully tragic story. In 2010, I can share you the details because it's all public knowledge. You can read this in the newspapers. In 2010, Mr. Razzouli presented with a brain tumor. He he only recently immigrated to Canada from Iraq. His wife, who's there, is actually an Iraqi physician. And unfortunately, he was diagnosed with a brain tumor and went for what was thought to be a fairly routine brain tumor resection. Unfortunately, it was complicated by devastating intracerebral infection, and the intense inflammation and difficult to treat infection severely injured much of his brain, and he was left really in a permanent vegetative state. And what did we mean by a permanent vegetative state? Well, it's really a state of wakefulness without any awareness. So if you go to the bedside to examine a patient in persistent vegetative state, you'll see the eyes moving around. You might see lip smacking. You might see the tongue moving. All the basic reflexes of the lower brain will be preserved. And you may even see the extremities move from time to time as different reflexes are activated. So it can be actually first somewhat put you off, thinking, oh, is this person really unconscious? But as you examine them carefully, it becomes clear that there's absolutely no evidence of any conscious activity, any awareness or appreciation or interaction going on whatsoever. It's a challenging diagnosis to make. But Mr. Razzouli was seen by many neurologists, and they all agreed that he was in a persistent vegetative state. How is it that this is possible? Well, I'll give you a little tiny bit of anatomy here. The consciousness is generated anatomically by a system called the reticular activating system that arises here out of the lower brainstem, spreads up through the midbrain to the thalamus, and then spreads diffusely throughout the cortex. And so you can lose consciousness either by having severe bihemispheric cortical damage, or by having severe damage to the brainstem and thalamus. And in Mr. Razzouli's case, he had severe bilateral cortical damage, but the lower brain was in fact entirely intact, which gives rise to this persistent vegetative state. So there was a disagreement between the physicians and the family, because Mr. Razzouli is in a persistent vegetative state. He's not going to wake up again. He will remain bedbound and ventilator dependent, and he had recurrent episodes of infection and sepsis. He had recurrent pneumonia. He was prone to different bed sores just by virtue of the fact that he's lying in bed for months. And so the future for him held out no particular hope. And in the judgment of the doctors looking after him, this was not consistent with the goals of life support. Life support was to achieve a meaningful recovery, and in their view, that goal was not going to be achieved, ergo the treatment is futile. The family disagreed with the doctors on two accounts. First of all, they disagreed that was the prognosis. They held out hope for a miracle, which we hear not infrequently, even from people who I suspect aren't particularly religious. But nevertheless, people hang on for dear life because trying to come to terms with this tragic new reality is just so incredibly painful. It's understandable, really. And so they wouldn't accept the doctor's prognosis. Secondly, they said that he was a devout Muslim, and that even if that was true, that was his prognosis, that he would want to remain in that state. And so that was consistent for him with benefit from life support. So clearly there was an intractable conflict, and so the doctors basically advised the Razzouli family that they had set a time at which point they would take Mr. Razzouli off of life support and let him pass away, and that if they wanted to prevent them from doing so, they would need to obtain a court injunction. So the family obtained a court injunction, and in the injunction obtained from the Ontario Superior Court, basically the judge held that inasmuch as withdrawing life support counts as a treatment, a new treatment, it requires consent, and therefore the physicians could not do it without getting the consent of the family. So now we get into this really weird semantic kind of debate about what it means to withdraw life support. Does it, normally, let's say like an oncologist is treating a patient with cancer, they're on chemotherapy for a length of time, the cancer progresses, and the oncologist says, you know what, this chemo is not working anymore. Why would I continue to put you at risk of all the side effects? We're stopping it. And really the patient has no control over whether the chemo gets stopped or not. You could go for surgery and have consented to, have a tumor removed or something, and if the surgeon gets into the abdomen or wherever they're looking and they find that whatever thought they were going to deal with is not the problem, or there's some complicating issue that means they can't do what they propose, they stop. They don't keep going, and no patient can force them to do that against their will. But in this case, the physicians are providing life support. They feel it's no longer a benefit, so they want to stop the treatment. But the judge is saying that to stop the treatment actually counts as a new treatment. Therefore, it requires consent. So I think the community of intensive care physicians was somewhat taken aback by this logic, but it proved decisive. The case was appealed to the Ontario Court of Appeal. The judge there ultimately ruled in the same direction, that because withdrawal is a new treatment, it requires consent. And the case then went to the Supreme Court of Canada. At this stage of the game, the Evangelical Fellowship of Canada, oddly, and the Euthanasia Prevention Coalition became involved in the case. And in intervening in the Supreme Court case, they argued that doctors should not be the ones to decide what the goals of treatment are. They felt that this would be an unfair imposition of sort of what's a fairly secular community on the values and beliefs of Canadians who represent religious beliefs and worldviews across the broad spectrum. So they felt this was an unfair imposition on patient rights. But I just want us to consider the question of who should decide what the goals of treatment are. Should it really be the patients or the substitute decision makers who decide what the goals of life support are? It's an interesting problem because it leads to a few kind of absurd consequences. First of all, if physicians can't decide what the goals of life support are, then I really have no grounds to withhold it from anybody, because in as much as they might decide, you know what, putting me on a ventilator will allow me to breathe for another 24 hours, that counts for me as a benefit, so you have to do it. Then I would be forced to put somebody on a ventilator when I know that there's no way that they're going to survive this critical illness. Another kind of really weird consequence of this subject-centered approach is that really there's no such thing as prescription drugs. So if a patient enters the doctor's office and says, you know what, I might not be having much pain, but I'm feeling kind of down and I really want some morphine because I know it'll make me feel a little better. And that counts for me as a benefit of treatment. What right would the physician have to say, no, that's not what morphine is for? Because if the patient decides the goals of therapy, then clearly we're at an impasse. And there's all kinds of other absurd consequences that we really don't have time to get into. So the point is, it's actually a difficult problem because I can understand on the one hand why people might not want doctors unilaterally imposing their values and beliefs, but at the same time to have the patients deciding the goals of medical therapy really is absurd. The Supreme Court ultimately sided with the patient's family and held that they coined a new term called health-related benefit, which is supposed to be somewhat different than a treatment, and said that because withdrawing life support is a health-related benefit, it requires consent, and therefore the physicians would have to obtain the consent of the family to take him off of life support. So now in Ontario, we are all bound to obtain the consent of families before taking people off of life support. My personal impression is that inasmuch as I cannot do someone much good if they are incapable of at least experiencing that good, recovery of consciousness ought to be a minimum criterion for benefit from life support. That's my own personal view, and I think it's pretty reasonable. But I recognize that there might be people out there who adhere to certain religious beliefs. Orthodox Jews, for example, some sects hold that just basic biological life with a beating heart counts as a benefit, and so my own view would conflict with theirs. So really these issues are kind of an intractable conflict of worldviews and difficult to avoid. And in the contemporary situation, autonomy rules, patient autonomy rules, and ultimately the only constraint on that will be when our resources become limited enough that we just can't provide life support for all these people who want to be maintained in that kind of a state. All right, so a number of related ethical issues arise. First of all, is withholding life support any different than withdrawing life support from an ethical standpoint? We kind of discussed this already. Before the law, they're treated as different. I don't need consent from the family to withhold life support because if, in my view, I don't think it's going to offer benefit of recovery or survival, then I'm not going to provide it. And the law sees that as perfectly permissible. But at the same time, if we stop life support because we think it's futile? Why is it that we're allowed not to start it because we think it's futile? So there's a deep inconsistency that we all see as doctors in the law, but such is the state of affairs. Now, this is a really important issue. Does withdrawing life support count as a case of justified intentional homicide? This is a critical issue because many people who argue for physician-assisted death, which we're going to discuss more in a minute, argue for the fact that inasmuch as we already intentionally end people's lives by taking them off of life support, what's really the significant difference between intentionally ending someone's life by administering sedative medication at lethal doses? So if we cannot ethically distinguish between withdrawing life support and actively ending someone's life, then they have a strong case to make for the legalization and the moral permissibility of physician-assisted death. Moreover, it would call into question the ethical character of withdrawing life support if there was really no distinction. So, in general, people have distinguished between physician-assisted death and things like withdrawal of life support on the basis that the one is sort of active and the other one is passive. This is the so-called doctrine of doing versus allowing. And it's been argued that there is an important ethical distinction between doing something to someone versus allowing it to happen to them. And this was my own personal understanding of the distinction for a long time, until I really started to read up and study these issues over the last few months. There's a really renowned moral philosopher by the name of James Rachels. And Rachels is a utilitarian. He's made the case for euthanasia and assisted death for many, many years. And he, in this kind of classic paper, described this thought experiment. He talks about this guy called Jones, who is a young cousin, from who, if the young cousin dies, he stands to gain significantly financially. And Jones one day wanders into the bathroom where his young cousin happened to be taking a bath, and pushes his head under the water and ends his life. That's scenario number one. Scenario number two is that Jones one day wanders into the bathroom and finds his young cousin taking a bath, but unfortunately he's slipped and fallen. His face is down in the water and he can't get up out of the water for whatever reason. And Jones stands there ready to push his head back under if need be, but it never becomes necessary, and the young boy drowns. So, would we consider the second case to be morally permissible, but the first morally impermissible? Is there really a distinction between the doing versus the allowing? I actually don't think so. Of course, the second case is morally heinous to allow someone to die like that intentionally. So he, I think, makes a strong argument that there is no ethically significant difference in the bare difference, all other things considered, between active and passive so-called actions. But is there any other considerations? Well, first, I think this thought experiment isn't exactly analogous to the case of withholding and withdrawing life support for a couple of reasons. First of all, Jones could easily have saved the child if he wanted to. He could have reached down, pulled him up out of the water, and consequently he could have saved him. Whereas in the case of withdrawing life support, really what we're doing is recognizing that there's nothing more we can do, that further intervention is futile. So there's an important disanalogy on that count. Secondly, when I take someone off of life support, it is not my intention to kill them. It is not my intention to end their life. My intention is not to continue a therapy which serves only to cause them further prolonged suffering. And my goal is simply to make them comfortable, to respect their wishes, to respect their dignity. I'm not hoping for, aiming toward the end of their life. In fact, I don't even know for sure if their life is going to end, although I can probably make a judgment that it's highly probable. So the actual distinction, I think, between physician-assisted death, euthanasia, versus withdrawal of life support is found in the doctrine of double effect. The distinction between intending and foreseeing a consequence. So is there really a meaningful distinction between intending and foreseeing? So if you undertake to do something and you know that it's going to lead to somebody's death, shouldn't you be held morally responsible for the fact that that person ultimately dies when you knew that would be a consequence of your action, or a very highly likely consequence? Well, the person to whom we owe careful analysis of this issue is Thomas Aquinas. And he was the first to describe what's been a long-standing doctrine in Catholic ethics, and really in the last couple hundred years made it into the broader discussion of ethics, the so-called doctrine of double effect. And Aquinas described three key features of cases like these. They had to be proportional, so that the thing that you were aiming at outweighed the harm of the thing that you weren't aiming at. Causality, your actions couldn't achieve the good by causing the bad. And for our discussion, intentionality. You had to be aiming at the good. That had to be your goal, but the bad couldn't be the thing that you were aiming at. So there's actually a huge debate about whether the doctrine of double effect is an ethically valid distinction. And many philosophers, particularly utilitarians, don't really find any weight in this argument whatsoever. There's only really one prominent atheist philosopher I know who holds that there is an important distinction, but he's a really good guy to have on your side. His name is Thomas Nagel. I don't know if anybody knows Thomas Nagel, but Thomas Nagel upholds an ethical distinction between intending and foreseeing, inasmuch as when you intend for something, it's your goal, it's what you're aiming at, it controls your actions. If you're not achieving that goal, you're going to adjust your actions to achieve that end. Whereas if you foresee something, it's really not controlling or directing your actions, and you're not going to adjust if you don't achieve that end. So he sees an important ethical distinction. But this is really critical, because if there's no distinction between intending and foreseeing, then withdrawing life support really is ending someone's life deliberately in a way that's probably questionable ethically. And this doctrine of double effect has all kinds of important implications in your lives on a daily basis. When Aquinas first described this, he was working out the problem of justification of killing in self-defense. Is it justifiable to kill someone because they're attacking you? He used this distinction between intending and foreseeing to make the case that it was. When you go to war, you know that there's going to be collateral damage, that civilians are going to die. Should the fact that collateral damage occur prevent you from going to war? Again, maybe the distinction between intending and foreseeing comes into play there. When we're sedating someone or treating their pain, because our goal is to treat their pain, even if we had to give sufficient doses to hasten their death, because I'm aiming at treating their pain, that's my goal, I think it's ethically permissible for me to give doses that sometimes might hasten death. Some other issues, this is a really challenging one in my view, is withholding or withdrawing artificial nutrition and hydration count the same as withholding or withdrawing life support? This is a famous case that probably many of you remember from the news a few years ago. This is Terry Schiavo. Terry was a young woman, again, in a persistent vegetative state. And it's amazing how photojournalists always find ways to present these patients as if they're actually seeing or interacting when they take these photos. Terry was in a persistent vegetative state and deemed to be so by many neurologists. So although she might appear to be looking at her mother here, there's really no conscious perception or awareness. And Terry's husband said, I don't think she would want to remain in this persistent vegetative state. She wasn't dependent on life support, but she was dependent on feeds through a gastrostomy tube. And so he said she, given her values, goals, and beliefs, would not want to continue the nutrition and hydration, and it should be stopped. On the other hand, the parents, first of all, they questioned whether she would want that, which complicates matters. But secondly, they basically said that under no circumstances should this be stopped, even if that's what she did want. So it became a very difficult problem. I think President Bush actually intervened to keep her on the nutrition hydration, although a court ultimately overturned that decision and feeds were withdrawn and she died several days later. This actually happens more than you think. And neonatal intensive care units across North America and Europe, disabled infants, severely disabled infants, are sometimes withdrawn on by stopping artificial nutrition and hydration. And this article is a painful read describing how the child basically shrivels up. The parents who made the decision not to continue artificial nutrition and hydration, basically disappear because they just can't come to see their disabled newborn dying this way. It's incredibly demoralizing for all those caring for the baby, obviously. And so, just the kind of ethical yuck factor that jumps out at you makes you think, can this really be ethically permissible? I think, again, the key, I actually don't profess to know the answer fully. I don't deal with these issues clinically myself, so I haven't wrestled through them. But I think a critical question we have to ask ourselves is, when we stop nutrition and hydration, are we intending death, or is it merely a foreseen consequence? I'm actually not sure of the answer to that question. And is stopping nutrition like stopping a ventilator, or more like asphyxiating someone and preventing them from getting any oxygen? Again, I'm not totally sure to the answer to that question. So anyway, there's lots of complicated issues around this. I'm just, part of my job this evening is just to raise awareness. I don't have all the answers. But I think I just want you to understand that there are people wrestling with these things on a day-to-day basis. All right, so much for withholding, withdrawing life support. Let's move on to physician-assisted death. Some important definitions. Probably most of you in the room are familiar with these distinctions, but just to be sure, I want to make them clear. Assisted suicide is when the physician prescribes or offers a lethal dose of a medication, but the patient administers it to themselves. Euthanasia, on the other hand, is actually when the healthcare provider actually administers the lethal drug directly. I don't think there's really any significant ethical distinction between those two. Some people have argued so, but most people don't find much of an ethical distinction. And finally, palliative sedation is simply when you get patients who have such severe intractable physical symptoms that you cannot manage them with kind of routine, aggressive pain management or nausea management and so on. So you actually sedate them, end consciousness until they die in order to prevent them from suffering. We kind of did that today, actually, on the person we were withdrawing life support on. So in my view, palliative sedation is not the same as, it's more like withholding, withdrawing. It's the doctrine of double effect applies, whereas with assisted suicide and euthanasia, death is clearly the intention. So for many people, that raises serious ethical questions. Now, the history of this debate around physician-assisted death is really, really interesting. This is, of course, Hippocrates, the man widely known for articulating the Hippocratic Oath, which included the commitment not to administer any deadly poison. And it's interesting to read about the practice in his day, because euthanasia and abortion and some of the other ethical things that we find ethically controversial were widely practiced in that time. And even many of Hippocrates' adherents who swore the Hippocratic Oath didn't really practice in a way that was faithful to the oath. Ian Dalbig, a professor in PEI, writes that in ancient Greece and Rome, before the coming of Christianity, attitudes toward infanticide, active euthanasia, and suicide had tended to be tolerant. Many ancient Greeks and Romans had no cogently defined belief in the inherent value of individual human life, and pagan physicians likely performed frequent abortions, as well as both voluntary and involuntary mercy killings. Although the Hippocratic Oath prohibited doctors from giving a deadly drug to anybody, not even if asked for, or from suggesting such a course of action, few ancient Greek or Roman physicians followed the oath faithfully. And in fact, it wasn't really until the rise and cultural dominance of Christianity several centuries later that these kinds of practices became seriously frowned on, and the Hippocratic Oath in its fullest form was seriously adopted as an ethic for practicing medicine. David Hume, just a few centuries ago, wrote that suicide may often be consistent with our interest and with our duty to ourselves. No one can question that, who allows that age, sickness, or misfortune may render life a burden and make it worse even than annihilation. So even a couple of centuries ago, when the Hippocratic Oath was widely endorsed, certain leaders in thought and philosophy were already beginning to discuss the ethics of the moral permissibility of suicide. And there were actually major movements to legalize physician-assisted death in the United States and Canada in the late 1890s with the rise of social Darwinism, and again in the 1930s. which were kind of kiboshed when the Nazi war crimes trials were held and all the deeply unethical practices of Nazi physicians were discovered. That really set the physician-assisted death advocacy agenda back by several decades. Ezekiel Emanuel, an ethicist and oncologist in the States, brother of Rahm Emanuel, mayor of Chicago and former assistant to Barack Obama, he does a historical analysis of these trends, and he finds really two concurrent social attitudes that seem to drive the debate. One was rugged individualism, an emphasis on the self and what the self wants, with less of concern for community or community needs. And secondly, questioning a physician's authority over medical decision-making. And it's kind of interesting because you look at the kind of contemporary scene, and I think both of those phenomena are really strongly at play in our society. Whether or not this is causal or merely just an association, who can be sure? The discussion within medicine was really facilitated by several physicians who took it upon themselves to do these things and dare people to prosecute or to pursue it. This story on this article on the left is an editorial about an article published in the Journal of the American Medical Association in the late 80s, where an anonymous resident physician describes going into the room of a woman who was in the terminal stages of metastatic gynecological malignancy, and she was clearly suffering horrifically. She was in terrible pain. She was weak. She was really in distress, and he writes that, or I don't know, actually I should say he or she, writes that the Debbie looked at him or her in the face and said, "Please end it," and without any more discussion than that, without actually really trying to understand what the patient meant by "please end it," could have been "please just manage the pain," but it may well have been that the patient was asking to die. This resident went and got a lethal dose of morphine and administers it. And in this anonymous article describes doing so. And this just created a huge uproar with all kinds of editorials. Of course, it was never disclosed who authored the article, but sort of a barrier had been broken into just describing what it'd be like to do this. This other article on a case of individualized decision-making was published by a physician in Rochester, New York, Timothy Quill, who's a world-renowned palliative care physician who describes assisting the suicide of one of his patients in I think it was in the early 90s. And again, this actually garnered widespread support within the medical community. Attitudes were shifting, and people began to think, maybe this is something we really need to start thinking about. This woman, you probably might recognize her. This is Sue Rodriguez. She was diagnosed with Lou Gehrig's disease, or ALS, and did not want to die naturally. And the reality is that we have to bear in mind that the people who are advocating, or these patients who are calling for the legalization of physician-assisted death, these people are really suffering terribly. And ALS patients really do suffer terribly. The loss of control, the loss of swallowing function, and many of them die by basically drowning in their own saliva. And so they require aggressive symptom management. But she didn't want to die with that loss of control, that kind of suffering. She wanted to be euthanized. So she took her case all the way to the Supreme Court, and in 1993 the Supreme Court ruled against her. And in that decision, Justice Sopinka, the Chief Justice, spoke of the generally held and deeply rooted belief in our society that human life is sacred or inviolable. And what's so interesting about this is that we've come a long way in 20 years, because the idea of the inviolability of human life doesn't even factor in the discussion anymore, because it just doesn't seem to be recognized that there's possible to uphold such kind of sanctity or inviolability of human life to many people. I'm not sure if you recognize this woman. This woman's name is Gloria Taylor. She also was diagnosed with ALS in, I think, 2010. And she also sought legalization of assisted death, and the BC Superior Court ruled in her favor and actually granted her the right to assist her death, but didn't allow anybody else to do it, but gave the government a year to develop legislation to permit it. Interestingly, she died of natural causes. She died of a perforated colon and septic shock and passed away in an ICU in BC. What's really interesting, though, is the reasoning that the judge in the BC Superior Court used to basically overturn a previous Supreme Court decision. And this judge argued that the law against assisted suicide infringed on the patient's right to life because, given her fear of losing the ability to kill herself, that might lead to the consequence that she would kill herself earlier than she actually needed to, and therefore the law against assisted suicide was actually shortening her life. Interesting logic. Secondly, the judge argued that it discriminated against people with disabilities because people with disabilities wouldn't be able to take their own life, and accordingly, they should be granted that ability. Given that suicide is actually legal in Canada, as you know, we wouldn't want to discriminate against disabled people by not enabling them or helping them to commit suicide if they wanted to do so. So the BC Court of Appeal overturned this decision, citing the previous Supreme Court decision, and in October of this year, the case was heard before the Supreme Court, and actually we're expecting their decision to come out anytime. The Chief Justice in the Supreme Court now, Beverly McLaughlin, was one of the judges who voted in favor of Sue Rodriguez in the early 90s. And so I fully expect that this court will rule in favor of the Carter case, and that consequently euthanasia will be legalized across the country in short order. And even if they rule against it, there is proposed legislation at the federal level and in several provincial levels to legalize it. So I think really the writing is on the wall in this issue. So let's get a little bit into the ethics. What really is the case for physician-assisted death, and what's the case against it? So let's begin with the case for. This is an article in the Canadian Medical Association Journal written by my close colleague, James Downer. James is a palliative care specialist and intensive care specialist at Toronto General, which is kind of sister hospital, and we've interacted a lot and worked together a lot over the years. And to be honest with you, James is a very good doctor. I have so much respect for him. I'm sure some of you know him and have worked with him. He's an outstanding physician, and if you have the opportunity to be cared for by him, I think you're in very good hands. So we have to just really bear in mind that in this debate, the people who are making the case for really are working with the best of intentions in their mind. We really have to understand and respect their position. And from James's point, and the way this case is argued in general, is that it's an issue of care, of compassion, and of respect. Basically, if you uphold autonomy to be a basic ethical value, we ought to respect patients' wishes. And if somebody wants to die and it's consistent with their values, beliefs, and goals, who are we to say no to them? That's the first case. Secondly, it's an issue of compassion or well-being. The reality is that the people who are asking for this really do suffer terribly. And they suffer not merely physically, but psychologically. They deal with fear, they deal with anxiety, they deal with distress. There is no question that medicine is limited, that we cannot treat all and every form of suffering. And so these people inevitably will suffer to some extent, although I think physical symptoms largely can be managed, as we'll talk about. And then thirdly, as we already talked about, many moral philosophers make an argument extending from the withdrawal of life support to the case for physician-assisted death in arguing that there's no important distinction between intending and foreseeing. So that's actually basically the case for euthanasia. And it's an easy case to make. It's simple, it's straightforward, and it has kind of curb appeal in our society. So how do we argue against physician-assisted death? And how, if you're going to talk to somebody on the street and you want to respond to this issue, what are some of the issues that you can bring up that really make a strong case against physician-assisted death? The first thing I think is that it's, in my view, insofar as many people today make the case that people suffer physically unbearably, it's largely unnecessary. I said earlier that medicine is limited and that it can't deal with some of the psychological suffering and some of the physical suffering they endure, but with good palliative care, with careful attention, respect, and when patients know that they're valued and that there's a commitment to their care, that they're not going to be abandoned, it really can dramatically transform the dying process. And the vast majority of palliative care doctors in Canada will testify to that fact, that good palliative medicine makes a dramatic difference. So in as much as people may make the case that by prohibiting physician-assisted death, we are forcing people to suffer unbearably, that's just actually really not true from a physical standpoint. People will suffer, but we can treat them and manage them in a way that they'll generally be able to tolerate that, and it can be a time of healing and good rather than a time of pure and unnecessary suffering. So there's a bit of an overreach on the part of the pro-PAD community in trying to make this an issue about unbearable physical suffering. The second thing that's really striking to me about this is that there's absolutely no scientific evidence that patients who are euthanized are any better off. We live in a day when evidence-based medicine is, for those of us who are in medicine, know that this is sort of the mantra. This is the goal. You know, when you go through medical school, you learn all these techniques for analyzing sort of studies to determine whether there's any evidence for or against a specific treatment. And so evidence, medical evidence, clinical evidence, science really is meant to undergird all clinical decision-making in the ideal world in the current medical paradigm. So what's interesting about this is that there's really no studies, and was a point, and as you'll quickly recognize, nor could there ever be a study trying to ascertain whether physician-assisted death offers a significant benefit. The benefit that is commonly asserted about euthanasia is that it reduces suffering. And this is sort of a consequentialist kind of utilitarian view that you can add up the total amount of suffering in your life, the total amount of pleasure in your life, and that on net, it's clear that life at this point actually kind of constitutes a harm in as much as it causes you to suffer. Therefore, it actually makes sense for you to end your life because you'll suffer less. The net harm will be reduced. There's just a number of important questions for us to ask someone who makes that kind of claim. First of all, how do you reliably compute the balance of benefit and harm if there's uncertainty about the remaining time and the quality of life that you'll experience during that time? The reality is that that it's hard to make predictions, especially about the future. And I was just reading a debate involving the president of the British Medical Association, Laura Finley, who's a palliative care physician. She describes the case of a young man with pancreatic cancer who asked to be euthanized, asked her to end his life, and she counseled him against it and changed his mind. And 11 years later, he's alive and well. And now his wife was dying of some type of cancer. She passed away. But she says if she had honored his request when everything looked bad, that those children would actually be orphaned. But by changing his mind, she was able to have such a good outcome. Now, obviously, that kind of turnaround, those kinds of unexpected turnarounds, are extremely rare. We're not talking about expecting miracles here. But the reality is that we're very bad at predicting how much time you have left. And we're very bad at predicting what your quality of life is going to be like that. And we're very bad at predicting what good palliative care can achieve. So there's a lot of uncertainty in making a recommendation to end your life now. There's uncertainty about how much the various kinds of pleasures and pains are worth. How do you compute the balance of net pain and pleasure? How do you compute the value of having your loved one sitting at your side by your bedside? Think about Brittany Maynard. She is, as you know, a young woman who ended her life because of glioblastoma. And she, in all likelihood, would still be alive and enjoying the companionship of her husband, enjoying the companionship of her friends. She might be physically suffering to some extent by now. But by ending her life prematurely, she may have incorrectly computed the balance of pain and pleasure that she was losing by dying. And finally, this is so important, is that there is no scientific evidence about what happens to us beyond the grave. Now, I'm not necessarily trying to claim that science ever could inform this kind of a question. But when someone says to you that it's better for you to end your life, they're assuming either that you're going to be annihilated or you're going to be in paradise. And that might be true, but we don't know, at least based on science. We have no science whatsoever to support that. So in fact, to claim that ending your life will count as a net benefit is a religious or metaphysical claim about with a blind faith-informed belief about what happens to you after you die. This is metaphysics-based medicine, not evidence-based medicine. All right, now let's talk about the harms to the public. There are a number of slippery slopes around physician-assisted death, and the weight of the public policy debate has been put on physician-assisted death, has been put on these slippery slopes, what the potential harms to society are. There's really a couple of key restrictions that advocates of physician-assisted death generally put on their proposal. First of all, they want to generally restrict it to those with terminal illness. That's what at least Canadian PAD advocates are saying. Secondly, they want to restrict it to those who can make a voluntary, autonomous, informed request for PAD. But if experience shows that over time, those restrictions easily become eroded. And first of all, we can see that the restriction of terminal illness can easily become eroded if the ethical basis for upholding prohibition for physician-assisted death is to honor autonomy and to work for well-being, and it's the patient who decides what counts as well-being for them and what counts as harm. If it's the patient who decides what the net pain and pleasure calculus looks like, then on what grounds can you possibly restrict it to those who are terminally ill with some physical disease? These are some individuals from Belgium. This is Frank den Bleeken. He is a serial sex offender who has been imprisoned in Belgium several times and has now not been out of jail since, I believe, the early 90s. And he recently requested euthanasia on the grounds that he knows he's never going to be out of jail. He knows he's never going to be able to overcome his sexual urges. So from his point, why continue to live? This is absurd. This is the Verbessem twins. They're in their mid-40s. They lived together. They had a full life. They enjoyed each other's company. They were deaf, but able to communicate with one another and with others. But in their mid-40s, they learned that they were going blind. And so when they found out that they were going to be deaf and blind, they both wanted to die together. So they were euthanized a couple of years ago. This is Nathan Van Helst, I believe his name is, born Nancy Van Helst. And he was the victim of a botched sex change operation. And he was so distraught by the outcome of the surgery that he decided he didn't want to live anymore. And he, in fact, was euthanized just last year because of unbearable psychological suffering. So there's a clear slippery slope here that it is very difficult to maintain this restriction to terminally ill patients, people who otherwise could be living full and meaningful lives or who could be assisted in doing so are instead opting for death. Secondly, the voluntariness restriction quickly erodes. It's a well-known fact that in the Netherlands there's something called the Groningen Protocol, which is the established protocol by which newborn infants are euthanized if their parents decide that because of their severe disability it's in their best interest not for them to live any longer. And just recently, this bioethicist at Queen's University, who was the lead author on the Royal Society of Canada Expert Panel on End-of-Life Care Report, he just published this piece in the Journal of Cardiovascular and Thoracic Surgery, arguing that it's ethical to euthanize certain severely impaired neonates. And so you see that in their minds, in the minds of these people who think carefully about these issues, given the moral framework that they have, given that we're interested in generating a sort of net calculus of net harm and benefit, very quickly you can justify all sorts of non-voluntary euthanasia. Another big concern about the practice of physician-assisted death in Belgium is that a considerable proportion of life-ending medical acts didn't actually receive explicit consent. And I just copied this off of a table. This is published in the Canadian Medical Association Journal just a a few years ago where they did this survey of physicians who had been involved in euthanizing somebody, and about a third of the doctors reported that they had been involved in administering a life-ending therapy without actually getting explicit consent from the patient. Now, a careful reanalysis of these data suggests that many of the cases here where the patient's explicit request wasn't obtained were sort of increases in pain medication that resulted in death. So maybe the doctors who reported this life-ending act without explicit request merely kind of misunderstood the survey question and included those patients in the survey. That's a sort of charitable interpretation of the data that many in the pro-PAD community like to make. But inasmuch as almost certainly there were some patients in here whose life was ended without an explicit request, that suggests that this law is just dangerous for society, dangerous for you and for me. And I think all it takes is one person whose life is ended without explicit request, homicide, for the legalization of physician-assisted death in Canada to be an absolute tragedy. There is, moreover, a more subtle pressure or erosion that can happen on those with chronic or advanced disease to be the considerate hero who does not stay alive too long using resources that could be better spent otherwise. This is Gillian Bennett. This woman ended her life, I think, in this last summer. And she wrote that I can live or vegetate for perhaps 10 or 15 years in hospital at Canada's expense. It is ludicrous, wasteful, and unfair. As we, the elderly, undergo manifold operations and become gaga while taking up a hospital bed, our grandchildren's schooling, their educational, athletic, and cultural opportunities will be squeezed dry. And she, for this letter and for her act of ending her own life, was praised as a deeply courageous woman who had the courage to do what the rest of us should seriously consider doing. Now, I just think about all the patients I've seen who lie in bed, who are severely disabled, who rely on the care of others all the time. If they were to pick up the newspaper and find this woman being praised for her courage, what kind of pressure that kind of puts on your psyche? What kind of questioning you begin to make about your own value, your own worth? Imagine going to your physician, where a physician offers you, say, oh, have you considered ending your own life? What kind of, because we're supposed to present all the options to people, what kind of effect does that have on your psyche? Moreover, can doctors really reliably discern when you're under that kind of pressure, when you're under that pressure from your family or from financial constraints? A detailed knowledge of the family and the patient's life is required. That's why initially people understood physician-assisted death to be administered by a family doctor who'd known you for many years and understood your life and the relationships in your life. But now in the Netherlands, in order to ensure the wide availability of euthanasia, there are actually so-called mobile death squads who you can just call up and they'll come to your home and end your life for you with sort of a cursory examination. So these are the kinds of consequences that societies that legalize physician-assisted death see, and certainly vulnerable people are put at risk. Interestingly, in the Netherlands, euthanasia rates are rising rapidly. This is a graph where sort of the rates of different procedures shown on the y-axis and time is shown on the x-axis. And the Netherlands, assisted suicide is this green line here, and euthanasia is this blue line here. And so you can see that while assisted suicide rates stay stable, euthanasia rates just sort of are taking off. And what's interesting about this is you kind of expect them to go up in tandem. If people are just sort of getting more comfortable with the idea of ending their life this way, you would expect assisted suicide maybe to go up more than euthanasia or about the same. But the fact that assisted suicide is not going up at all and euthanasia is going up entirely suggests that euthanasia makes it very easy for people to come to terms with this, whereas they're unwilling to actually do it to themselves. So all these kind of data, these slippery slope data, raise serious concerns about the safety of the procedure. Now, I think the critical issue, and I'm sorry, I know that we're going on for some time, so I'll try and end quickly here. The critical issue for us is it immoral to intentionally end someone's life? Is it immoral to intentionally cause the death of an innocent human person? Because if in fact it's not immoral to do so, if it doesn't really matter from an ethical standpoint, if you can justify it in these cases, then all these slippery slope danger concerns that we've just described probably don't matter that much. And I think the critical determinant of the people who really care about the dangers and slippery slopes versus the people who don't really care is their underlying view of the morality or immorality of intentionally ending someone's life. Now, there are two basic schools of thought around the basis for holding that it's immoral to intentionally end someone's life. This is Jeremy Bentham, the father of modern utilitarianism, and this is Peter Singer, probably the world's most influential living philosopher, a well-known utilitarian animal rights activist. And their basic viewpoint is that a person's preferences determine the value of their life. So again, autonomy is the foundational ethical value. And if you value your life, then it's valuable. And if you don't, then it doesn't have basic value. They see killing as wrong, A, because it harms you, and B, because it violates your autonomy. And they hold that physician-assisted death doesn't actually violate either of those issues because it actually counts as a benefit and it's not violating your autonomy, so therefore it's perfectly justifiable. And I think if you talk to people on the street today, that's exactly their understanding of the wrongness of killing. It counts as a harm and it counts as a violation of your autonomy. And if you can make the case that it doesn't count as a harm and doesn't violate your autonomy, then to them killing seems perfectly permissible. I know that's what I've encountered in the kinds of conversations I've had. The second is the sort of deontological school of thought, where the basic viewpoint is that people are more important than their preferences, and that their preferences only matter insofar as they foundationally matter. This kind of a view has been advocated for a long time. Thomas Aquinas here again, one of the leading figures in a certain school of deontology. This is Immanuel Kant, who tried to develop a rational case for the value of human life by saying that rational beings must be treated with respect. It's wrong to use ends merely as means to ends. And if as much as killing yourself is using yourself as a means to an end, it's wrong to do so. That's basically the Kantian deontological argument against killing yourself. But I think that the key problem with trying to advocate any of these ethical theories is that they're subject to the problem of arbitrariness. Why is it that I should respect someone's autonomy? Why is it that someone's autonomy should be determinative of whether or not they have value? Who makes that rule? Who says so? On the other hand, why is it that rational beings ought to be treated with respect, or they shouldn't be used as means to ends? Who says so? Where does that rule or prohibition come from? What really is the foundation for these schools of thought? And it's interesting because in medical school I found time and time again that people accepted autonomy and beneficence and non-maleficence and justice as sort of basic values without actually trying to justify them as true ethical values in any way, shape, or form. So for this reason, I'm an adherent of divine command theory, at least a modified version, where ethical norms come from God, who transcends us so that we are universally subject to these norms. This is a view that's espoused by a number of contemporary and classical philosophers. And really, I think it's the Christian understanding of the ethical, the basis for ethics. Humans are made in the image of God. As Gilbert Mailander, a leading Christian ethicist, has written, each person's life is a divine gift and trust. Our lives are in God's hands. We are characters playing a role in God's story, not our own. And therefore, we don't hold our lives. We don't have the privilege of deciding whether or not our lives should be ended or not. Those things we have to leave in God's hands. And in Scripture, there are repeated prohibitions against the intentional ending of innocent human life. So, to summarize, these are complicated issues. The slippery slope arguments that we've made, I think, are important, but bear a variable degree of weight depending on your view of the morality or immorality of intentionally ending life. And experience suggests that physician-assisted death will grow in frequency and that indications for it will expand. And really, I think that your view of physician-assisted death is entirely predicated on your view of metaphysical reality, what it means to be human, what it means to have a purpose in life, what are the basics for ethics is. We really have a conflict of worldviews. So now we're quickly going to move to the conflict over the end of life. This is a paper that was published in the Journal of Medical Ethics a few years ago, which found that atheist or agnostic physicians were more than twice as likely to have administered life-ending therapy or to have had a discussion with a patient about doing so than religious physicians. And really what this kind of confirms is the significance of one's global worldview in approaching these kinds of ethical issues. It's interesting because the author here recommends that you actually go and explore your doctor's basic beliefs about the world, because to try and understand what they're going to recommend to you around these issues. And I think there's some justification for that. Reading the culture that we live in, let's just think about for a minute what it's like to live with a secular mindset. The heavens are closed. The cosmos is entirely composed of matter. It exists mysteriously without explanation. Everything that's real is something you can reach out and touch. It's immanent. It's what Charles Taylor said, that we live in the immanent frame. Everything around us is, we don't imagine that there's anything beyond us or out of our sight or out of our touch. Humanity appears by accident. We're possessed of no definite purpose or value. The very definition of a person is currently up for grabs. If you've read anything by Peter Singer, you'll know that in his view, many animals satisfied criteria for personhood as more than some humans. And so the huge problem we run into is that when you have this understanding of the world, is that you are essentially what you make yourself to be. The famous French existentialist philosopher said that man is nothing else but what he makes of himself. He argued that a consistent working out of an atheist worldview is that existence, the fact that you are a subjective center of consciousness, precedes essence. So that means you define yourself, you define what you are, you make yourself to be what you want to be, and consequently you are the author of your life story, you're the master of your fate, you're the captain of your soul. Existence, therefore, also precedes ethics. You become the chief end of your own life. Autonomy becomes the fundamental ethical virtue, as we talked about, and really the only absolute is respect for the autonomy of others as we respect our own. Sort of a new version of the golden rule. Our own flourishing is now the end of life, and ethics are defined completely in these terms. Moreover, secular ethics, consequently, are a very tenuous status, and somebody's going to call the bluff. Why should we respect others' autonomy? In Fyodor Dostoevsky's classic novel, The Brothers Karamazov, Ivan, one of the brothers, says, if God is dead, everything is permitted. Friedrich Nietzsche called this bluff when he wrote in his Parable of the Madman. The madman jumped into their midst and pierced them with his eyes. Whither is God? He cried. I will tell you, we have killed him. You and I, all of us are his murderers. But how did we do this? How could we drink up the sea? Who gave us the sponge to wipe away the entire horizon? Whither are we moving? Away from all suns? Are we not plunging continually, backward, sideward, forward, in all directions? Is there still any up or down? Are we not straying as through an infinite nothing? God is dead. God remains dead, and we have killed him. And Nietzsche's recognition that with the death of God, everything is permissible, there are no constraints or direction, no up or down, was the worldview that led to World War I and World War II, and the awful suffering and wickedness that came with it. Of course, there's also the malaise of immanence, what Charles Taylor referred to as the malaise of immanence. Our actions, our goals, and the like have a lack of weight or gravity, thickness or substance. There's a deeper resonance that we yearn for that they lack, which we feel should be there. Life, in essence, because it's meaningless and pointless, feels absurd. The French writer Albert Camus compared living life in this sort of meaningless, absurd environment to the Greek mythological figure Sisyphus, who was condemned by the gods to push a rock up a mountain until he got to the top, at which point the rock would roll down the other side, and then he would push the rock up the other side, at which point it would roll down again, and to do that for the rest of eternity. And he likened that to what it's like to live with this sort of empty, absurd life. And so he said there is but one truly serious philosophical problem, and that is the question of suicide. Should we continue to live in the face of this absurdity? And the reality is that suffering only heightens the absurdity of life, if this is true. When pleasure is no longer a possibility and life holds only pain, then why persist in pushing the rock up the hill? Euthanasia is then a last, desperate declaration of self-assertion in the face of absurdity, shaking one's fist at oblivion. And it's interesting because 90% of patients presenting to an end-of-life clinic at the Seattle Cancer Center reported that their main motivation for seeking physician-assisted death was a fear of loss of control, loss of autonomy. So into this darkness and gloom, the light of the gospel shines. Matthew wrote in chapter 4 of his gospel that the people dwelling in darkness have seen a great light, and for those dwelling in the region and shadow of death, on them a light has dawned. For Christians, the heavens are open, and contact with the transcendent is possible. We understand ourselves to be the crowning glory of God's creative activity. We're made in the image of God and created to exercise dominion on His behalf, and our lives are consequently of incalculable worth. Consequently, in the Christian worldview, meaning and purpose and value are real, not merely a fiction we make up for ourselves. And ethics are built on absolute norms derived from divine revelation. They transcend social, cultural, historical, and economic conditions. The meta-narrative of the gospel offers a way to make sense of the human predicament, and it's of particular significance for those who are sick and suffering. It offers us the possibility of deep meaning and purpose for our suffering. Our lives are part of a grander story that transcends us, and consequently our suffering can have true meaning. There's an infinite good that tips the scales of pleasure and pain toward life and living under any circumstance. Because for us, suffering cannot take away what we truly need, and that is fellowship and communion with our Maker and friend. How then can we decide between these views? Why should we hold to the Christian worldview and not the secular worldview? Why is it that we believe we have genuine meaning, purpose, and value, and not absurdity? And fundamentally, I think the answer is found in the historical facts of the life, death, and resurrection of Jesus Christ. As Jung talked about at the beginning, God's decisive actions in human history make possible the knowing the reality of the transcendent. And as one who makes his living by thinking critically about science, about medicine, about life and death, I'm wholly convinced, based on the evidence, of the truth that Jesus rose from the dead. And because Jesus rose from the dead, I'm a Christian. Because I'm a Christian, my ethical beliefs are based on God's revealed view of reality, not man's perception. And inasmuch as God has made it clear that our lives are in His hands and not ours, I cannot assist in death. So in the final analysis then, I as a physician will not assist in death because I believe that Jesus rose from the dead. So just to summarize, the case against physician-assisted death: A, it's generally unnecessary from a physical symptom standpoint. B, it's dangerous. It's quickly the non-terminally ill may be seeking and receiving it. Those who are not requesting euthanasia may be receiving it. And it's importantly, it's wrong. It violates the sanctity of life. People are more important than their preferences, but ultimately the justification for that claim is found in the life, death, and resurrection of Jesus as historical facts. So, very quickly, how do we be salt and light in the face of these issues? I think basically four things. First of all, we need to incarnate God's love to the suffering through deep empathy and humble service. And those of us who work in healthcare in particular must be absolutely devoted to high level of expertise in preventing and treating pain and suffering. We have a huge obligation to model that for the world. Secondly, we need to pray for those who sit in the shadow of death. Society wants euthanasia because it makes sense to them, because life is absurd for most people in our society, even if they don't realize it, even if they couldn't articulate it in that way. So our world sits in the shadow of death. We need to pray for the world around us. We need to share the gospel, because ultimately that will resist calls for physician-assisted death. We need to be willing to bear witness to the truth of the gospel and the truth of the resurrection. We need to be willing to explicitly link our refusal to participate in these things and the grounds of our ethics in the gospel. And that's a difficult thing to do because for many people it seems utterly implausible. So we have to be prepared to make the historical case for the resurrection of Jesus Christ and to use that as a firm grounds for your ethical standards, because the reality is that the secular people that you encounter don't have any firm grounds for their ethical standards whatsoever. And finally, we need to demonstrate clear and consistent ethical standards. We need to be willing to step up, to stand up, to speak out. This is not an issue that I ever envisioned speaking out on or making any kind of public statement about, or getting up at a conference and questioning the person who's proposing it. This is not, I just want to spend my days measuring pressure inside the chest and resuscitating sick patients. To get involved in this complicated ethics, they're controversial, they call up all sorts of issues and conflict. This is not really what I envisioned for myself as a doctor, but here we are because this is what the day calls for. One way that you can speak out is by spreading the word in social media. This is an article that Stephen Huang, a professor of medicine, internist at St. Michael's, and myself published on the Canadian Medical Association Journal blog. Just came out this afternoon. This is my first and only blog. They wouldn't accept it in the real journal. But if you can spread this on social media, this would be a way for you to speak out on the issue. In this article, we basically explicitly link our belief in God and grounds for it to the fact that we will not participate in physician-assisted death. And I hope that this serves to make the case to the world to understand that the real grounds for ethics are the fact that God exists, because if there is no God, then everything is permissible, and we really try to point that out in this article. There's lots of uncertainties that I still have around these issues. Does making a referral make one complicit? I think so, but some people might not agree with me about that, and that's a conversation I'd be very interested in having. Should we expect or aim to have the laws of the land reflect moral standards that I've explicitly linked to my metaphysical beliefs? How can Christians more explicitly integrate the truths of the gospel into their work in healthcare? The reality is that there are now huge barriers to us to talk to our patients about spiritual issues. And I understand to some extent why those barriers exist. Physicians and nurses and health practitioners have a considerable power or influence over their patients. So in many cases, it's not appropriate for us to be proselytizing our patients because of an undue influence. But nevertheless, when you see that people are suffering and you know that you're holding this treasure that helps them to understand and make meaning and overcome and transcend their suffering, and it completely changes the outcome of death, then it's very difficult to sit back and say, yeah, this has nothing to do with how I practice medicine. And wouldn't it be amazing if we had a kind of a Christian healthcare service as sort of a subset of healthcare in this country, where people knew if I was going to go to that physician or this nurse practitioner, that they're part of the sort of Christian practice, and that belief system is going to be built into that, and they would be, by the exercise of their autonomy, choosing to receive that kind of care. To me, that would be an amazing way for the system to work, and I think the regulatory system, such as it is, makes such a thing difficult. But we need to think carefully about how it is that we as Christians can explicitly link care for the suffering and the gospel in a way that genuinely transforms lives. All right, I'm finally done. Thank you very much for your attention, and I really appreciate the opportunity. I don't know, do we have time for questions still? Or? I don't know if anybody has comments, questions. Paul.
Just on the second point that you had in that last slide, I feel like that's kind of some of the questions really where it may come down to. And as Christians, we might have beliefs that dictate how we would say what is right and wrong. Where do we stand in a society where perhaps the majority even doesn't share that moral basis? And I guess you can still, that doesn't mean you should therefore be silent and not advocate. So how does that kind of work? I mean, like what you're saying, something's coming through the Supreme Court right now, which may well be in violation of your beliefs. You still have a voice in the society because it advocates that, but then how can we work with expectations? I was wondering if you could just say a little more on that.
Well, and it's an area of uncertainty for me, Paul, so it's difficult for me to comment in detail. I was hoping to get you guys to comment. But, what I will say is that I think there's two schools of thought around this. There's maybe the somewhat idealistic school that says, well, you know what, we have to accept that There's different basic worldviews coexisting in this pluralistic society, but in as much as we all value tolerance, those who wish to practice this can do so, or might be legally permissible for them to do it, and we'll just say we don't do that, and then we can make our case and say, you know what, we think this is wrong, and we think the gospel's true, and here's why. The problem that seems to be that many people raise, and that seems to be even occurring now, is that it's very difficult for genuinely conflicting worldviews to live together side by side in harmony. And a good example of that is the College of Physicians recently proposing to mandate referral for some of these ethically controversial procedures like abortion and euthanasia, and basically requiring, for there's been a long-standing sort of acceptance that those who are against it, can just say, I don't offer this, and you can go to a different doctor to seek assistance for this, and that was the end of the story. But now there seems to be a sort of belief that if you want to practice medicine in contemporary secular society, in as much as the government is secular and society is predominantly secular, and doctors are paid by the government, and where health care is paid by the government, and it's a public right, then it ought to be delivered in a secular fashion. And consequently, those people who, for no good reason are objecting, should at least be forced to refer in order to respect the autonomy of the patient. So it's kind of a conflict between physicians' conscience rights and patients' rights, and the autonomy. It's just odd to me that the autonomy of the patient matters more than the autonomy of the physician, except that one could argue that physicians hold an undue influence or power. So
that's intriguing, because some of what you're putting it is actually there's a inconsistency within a secular society, which is where the religious individual in the secular society cannot be a full individual to the degree that the secular individual can.
Yeah.
And that's just that's actually an inherent part of the society we constructed and live in.
Absolutely. And in fact, in this blog piece, that was exactly the thing that we wanted to resist. So we basically argued that that in the debate over physician-assisted death, those who understand ethics from a theistic framework and from a secular framework uphold the same basic set of values. We both support the importance of autonomy. As Christians, we fully believe that in as much as we're made in the image of God, our autonomy ought to be respected, etc. We both uphold the worth of life. PAD advocates are not going around saying that human life doesn't matter. We both uphold the importance of compassion. The key difference is that we rank or order or prioritize these values differently. So the question is, which worldview or framework does so in a better or more coherent way? And we basically argue that secular ethics is incoherent. It doesn't have any basis for upholding the value of autonomy. And it's interesting to read the Royal Society of Canada report, which basically argued for physician-assisted death by saying autonomy is sort of the current consensus value in Canada, so clearly physician-assisted death ought to be legalized unless there's some other good reason why it ought not to. And then they basically take down all the arguments against and presume autonomy and presume that the right to death follows from that. So they try to ground autonomy in the fact that autonomy is respected in our Constitution and in our political order and in previous court decisions. But as we point out, all that does is prove that autonomy is highly valued in our society. It doesn't actually provide any kind of epistemic basis for saying why we know that it actually ought to be valued in that way. So there, as the picture of the house on the stilts, their framework is basically sitting on very tenuous grounds, and we're just trying to call the bluff. And then we go on to say that doctors need to be, in as much as we make decisions that affect the lives of others, we need to be responsible decision makers. We need to be rational, because rationality is a minimum criteria for being responsible. And that then we ask the question, is theism rational? And we basically briefly say that it is, citing some other things, and even try to cite some unbelievers in making that case. And so basically we're just trying to stand up and say, yeah, you know what, theism is as valid and possibly more coherent than your system. Therefore, we have every right to abstain from this, and we're not going to be pushovers. Yeah. So get on Twitter and spread the news.
Do you have any experience or comments about practicing a little bit of ecumenism, maybe perhaps joining other religions who have who hold a similar theistic attitude, like certain Jewish faiths?
Yeah.
And been talking to them and basically advocating for very similar things to what we are.
Yeah. Yeah, well, absolutely. I mean, in as much as they hold the same basic beliefs about the intrinsic human value, we can certainly be allied with them. And, I've actually been interacting with a lot of Catholic physicians. It's interesting because many Catholic physicians have a more finely tuned ethical conscience than some Protestant physicians I'm encountering. So within Catholicism, there's been a long-standing commitment to social justice, to ethics. They've always been very active in the abortion issue and so on. So, whereas I think there are critical differences between us, theologically and in terms of the gospel, nevertheless, there's clearly we need to work with those who share our basic values. Whether they can justify them as well as we can is a whole different issue. But I'm always thankful to meet people who understand that human life is inherently valuable, whether I think that or not. That's just, it's interesting just how happy that makes you, because it's oddly rare these days. I don't know, how about yourself in your practice, in your encounter with these issues?
Yes, one of my closest colleagues who practices palliative care, practicing, so it's not a Jewish person, like the Allen, and another pediatrician is a Catholic, and we do often discuss these issues.
Mm-hmm. Mm-hmm. Yeah. Absolutely.
This whole topic is really intriguing to me because I deal with a lot of chronic pain patients who have a high risk of depression and suicide. And there are a few clients that I've had that had committed suicide, and you can do the checks, you can actually give them support, refer them to psychologists or psychiatrists, but as they're more determined in making it happen, they make their means of making their ending happen and committing the suicide. So there's people that have stockpiled meds, they've done carbon monoxide or jumped off buildings, and I almost wish that, not to say that I want physician-assisted suicide to be legislated, but it gives that chance to have the conversations, because once people talk about wanting to go through that process, I feel like there would be many more checkpoints to have opportunities to have conversations, because with the clients that I experienced where they were wanting to bring up suicide, we would always try to talk them out of it, refer them to services. And it came to the point where they also knew the answer of how we would try to prevent them from going down that route. But when they were determined, they actually stopped talking about it, and it didn't give us a chance to give them dignity in that process. So when you talk about Brittany Maynard, who actually had the plan, was able to be in an uncomfortable environment where her families were there and everyone was prepared, versus someone who actually has talked about it, but the outcome with our legislation is they do it in a place where they're scared, they're alone, people don't know what their day is, and they find them sometimes very surprised and very saddened to know that their loved one actually did these acts. So it's really hard to reconcile what a good process would be, because people who are determined to end their life actually will.
Right. So you're kind of saying that in as much as those who are determined to end their life will end it more comfortably if it was legalized, it kind of makes you feel like there's an obligation to make it a safer way for people to carry out the act in a way that's legally permissible. Yeah, I understand. I understand that sentiment. It's interesting because people make the analogous argument about abortion that even if abortion is immoral, women were going out and doing it to themselves and severely injuring themselves as well as the fetus, and it led to a lot of harm. Consequently, now the doctors are doing it for them. It's much safer for them. Ergo, it should be legalized. And I think that this exact issue is why it is so critical for us not to try to make the case primarily on the consequentialist kind of issue, the slippery slope, the danger to society, but to actually address the issue of, is it immoral to intentionally end someone's life? Because to me, the only real barrier to not ending someone's life, when they come to me and sort of perfectly capable, perfectly aware, sort of fully autonomous, as if that ever really exists, say, I want to end my life. I've had enough. I can't deal with this anymore. And it sort of seems to make sense given how much pain they're dealing with. The only real thing to me that would stop someone in that situation from offering them would be the belief that it's wrong to intentionally end innocent human life. And so if it's truly wrong, if it's truly immoral to do that, if it's as immoral to do that as it is to end the life of a young child, or if it's wrong to end human life, then the circumstances, the consequences of prohibition don't really bear that much, because we do not want to facilitate what we consider to be an evil. So if you're convinced that it's evil, then even this disappointing, kind of difficult outcome or unwanted outcome of prohibition, still it would be insufficient to justify the practice. Now, that being said, I think that we need to handle these issues as Christians in a way that makes clear that we value grace, and we understand that there are temptations to do this kind of thing, and we want to be open, have those kinds of conversations, that we really care. And we're not going to be able to help individuals, you're absolutely right, if we can't have the conversation. So we need to approach this in a way that's not harsh or unnecessarily judgmental, to demonstrate care and compassion. And you could even be proactive and say, some of the patients, some of my clients sometimes wrestle with the feeling like they should end their life. Does that ever happen to you? There are grounds to be proactive around it for sure. But I don't think that just because someone then goes on and takes ownership of an evil and does it to themselves, that we should necessarily feel obligated to widely permit such evil to take place. And one of the things that really strikes me is that in the secular worldview, for this guy Frank Van den Bleeken, this serial rapist who's stuck in jail and knows he can never overcome his sexual urges, how grievous is it? He has no idea what grace looks like. There's no possibility of redemption for him, so he's just going to end it all. Whereas in the Christian worldview, we're all sinners. We all struggle with all kinds of evil within us that we find, but there's grace for us. There's opportunity. There's redemption. There's restoration. So I just, over and over, these issues just highlight to me the critical issue of what you think the end of life is, the purpose, the meaning of life, and that's really what we need to be effectively addressing. So anyway, that's a very long-winded response. I'm sorry. Anybody else?
I find it hard, I know we've had a lot of discussions in the program about this too, how I know with palliative care with physical symptoms, a large part of those can be treated by sort of the psychological suffering of people who lose their ability to speak or to think or to communicate to their loved ones. How do we sort of address those types of suffering, knowing that Christ is sort of the answer for that, but not being able to fully sort of give that, hold up that answer? I find that hard to do.
Yeah, I agree. It's very difficult. I don't know, to be honest with you. I mean, I think one thing we can pray for people, pray that God opens doors and opportunities. I mean, I think if people are proactively seeking to talk to you about those things, then maybe the door is a bit more open than otherwise, and God can open that. So God can open a door for those conversations. But I agree with you. I think we just have to rest, trust God, model, love them, care for them, and really, we all believe that God is sovereign. He's in control. He's all wise. He's all good. So we just have to leave those things in His hands, I think. Yeah. don't know how.
For time's sake, we have to end the official portion. We'll continue to ask some questions privately.
Yeah, of course, yeah.
If you have more questions, please come up afterwards. But you're officially dismissed, and we have this room until 9 o'clock. So feel free to mingle, meet each other, and ask questions. And thank you again for your great talk and intelligent talk, and it's very relevant to all of us here. So thank you very much.
All right, thank you.